What you are about to hear is going to be 75% serious talk. 20% will be two old guys going down a rabbit hole and telling stories about football and rodeo and being at least 5% funny. Please be aware that we may not be grammatically correct or even sound like we know what we are talking about, but we are trying our best to learn and cope with the cards that have been dealt to us. We believe that we can bring hope to those who suffer and help in any way that we can. This is the Headrush Podcast with Paul Fraze and Corey Berry.
Welcome to the Headrush Podcast, where we talk about everything surrounding traumatic brain injury, suspected chronic traumatic encephalopathy, and repetitive head impacts. We will explore symptoms like mental health issues, depression, addiction, apathy, suicide ideology, diminishing executive function, memory loss, and degenerative neurological issues. But most of all, we can't stress this point enough. We will talk about hope and we will raise awareness. We truly believe that awareness leads to hope, leads to actions, and finally leads to positive results. Today, our esteemed and world-renowned guests today are Doctors Mark Gordon and Dr. Mizyl Damayo. And Dr. Gordon just told us that he goes by Mark, so I think that's the last time we're going to say Dr. Gordon. But Mark is the owner of and medical director of the Millennium Health Centers. His second book was released in 2015 titled Traumatic Brain Injury, a Clinical Approach to the Diagnosis and Treatment. The book is right there. It's my second Bible, lowercase b. And it's a highly scientific book, but it taught me a lot about neurology and the brain and inflammation. So, Dr. Gordon is a frequent guest on the Joe Rogan Experience to discuss traumatic brain injury, among other topics. And I know he is most fond of the work he's accomplished through the Millennium Warrior Angels Project, which he teamed up with Green Beret Andrew Marr and his brother, Adam Marr, who was an Apache helicopter pilot, co-founders of the nonprofit Warrior Angels to help veterans regain their lives back. And also with us is Dr. Mizyl Damayo, the medical director of Paradise Behavioral Health, located in Punta Gorda, Florida. And Corey and I have actually something in common. Dr. Mizyl Damayo is our doctor. So Dr. Damayo is certified by the American Board of Psychiatry and Neurology, as well as the American Board of Addiction Medicine. Dr. Damayo's primary areas of expertise are addiction medicine, depression, and anxiety. She also focuses on precision psychiatry, and I know we're going to get into a lot of that subject. And integrative holistic psychiatry, lifestyle management, traumatic brain injury, neuroendocrinology, and TMS. So a huge thank you and a huge welcome to Mark Gordon and Mizyl Damayo. Both are esteemed doctors and friends, and we are so appreciative that you joined us today on the Headrush Podcast. And
thank you, my Dr. Damayo. We call her Mizyl, and thank you, Mark Gordon, for showing up. And I just want to bring something to attention, Mark. I was talking to a friend of mine the other day, and he wanted me to talk to you personally. He wrote a book, and it's on our front counter here, called TBI or CTE, What the Hell is Wrong with Me, Mr. Mark Tullius. You're in the book. He's talked about who all he's seen and everything he's done. And he went and saw Allison. And he's doing great things with it. That's a great book. And he just wanted me to say thank you from him and that he owes you huge. Mm-hmm. And just to say thank you, Mark.
Well, I remember Mark, and he saw my daughter, Allison Gordon, who's a naturopathic physician who's been with me over 10 years. And she brings some major expertise to us because there's an area of traumatic brain injury, CTE, Alzheimer's, Parkinson's, MS, ALS that we keep on missing. And that's the gut, because the gut sends a lot of chemistry into the brain that creates this inflammation. And what the inflammation does is it generates two very primal chemicals, proteins that create everything that we call CTE, MS, and all these labels that we put onto these conditions, which I'm adverse to. I think looking at the foundation of inflammation, well, when you have inflammation, regardless if it comes from chronic stress, emotional stress, or it comes from being blown up by an IED, overpressure, repetitive gunfire, a car accident, a motorcycle accident, a slip and fall, or an assault on the brain, it all generates an inflammatory environment in the brain that does what? It causes two things to happen that are consistent throughout all those neuroinflammatory conditions, such as Mark wrote about with CTE or TBI. And that is the tau protein and beta amyloid. So beta amyloid is what we look at intensely as being the causation for Alzheimer's disease. And then the neurofibrils, which come off of the hyperphosphorylated tau protein, is what we look at as being CTE. But in the project that I'm working on right now, it's really a research review, is that in all those neuroinflammatory conditions, you've got both those chemicals, both those proteins, the beta amyloid and the neurofibril tangles. So when Mark asks the question of, is it TBI or CTE? Well, yes, it's all that, because they come from the same foundation. And so the way that we've been able to reverse multiple sclerosis, which has a large component of the CTE component and this neuroinflammatory environment, is we can reverse it, as we did with Parkinson's and Alzheimer's and so forth. But you have to address the causation, not treating the symptoms. You have to treat the causation. And that's why when I look at Dr. Damayo, she's, I don't know if the right term is unicorn, but she's unique in the fact that she came to us almost 4 years ago. And, with the understanding that what she was anticipating and doing in her field of psychiatry and addiction medicine and so forth, and depression, anxiety, all the neuropsychiatric conditions was not being accomplished to the degree that she wanted. And she realized there was something missing. And through awareness, two key words you said, awareness and hope, absolutely. Through awareness, she became educated on the technology that we've advanced over 30 years. And she gave her clients, her patients, hope. And I was getting weekly reports of people that she had been working with, that she'll tell the story specifically, that had gotten their life back without medication before they were being interred in psychiatric institutes. That's what we need. We need more psychiatrists like Dr. Damayo to be able to say, hey, I'm not achieving the goals that I thought I would without putting people on so many drugs that it makes them zombies. That's not living. Okay, I took care of depression, but they're in a bed 18 hours a day drooling, and then they're out of bed for 6 hours? Got to do my math. So anyway.
So I met Dr. Gordon first of all on the video camera. A friend of mine suggested I watch the movie Quiet Explosions, and I watched it, and I've watched it about 9 times, and I felt like a friend of Dr. Mark's before I even met him. And truth be told, I kind of stalked you down to AMMG when you were doing your conference down in Doral in Florida.
So being a stalker, Mark, since you just mentioned the word stalker, I'd lock your doors at night and maybe turn off your cameras.
Right. I didn't call the police yet.
Well, it's interesting because
he came to the class and took the class, which is a high-end class, and he sat there. He didn't sleep too much, though.
Yeah, but I had that glazed over look in my eyes after the second or third session, and we had 8 or 10 sessions that day. So And that's why I came back 2 years later and witnessed you again. And wow. So, we have to unravel your opening statements. And Corey, being a strong Texas advocate of women and ladies first.
Right. Here in Texas, we always say ladies go first. We open the doors for ladies. We do all of that here. Well, you live in Texas now, Mark, part-time, so welcome.
Yeah. Thank you.
Yeah.
You may not be in the best part of Texas, but you're in Texas.
No, I've heard that.
Yeah.
The best part is the food and the people. People and the food. It's nice being in a comfortable environment as opposed to the time that I've spent in California. And hopefully a lot of California is going to start changing.
Oh, hopefully. I'm from Bishop, California, born and raised. And I tell you what, I absolutely adore the Sierra Nevadas and living up where I grew up. But with the way California is now, y'all can have it. I'll just stay over here in Texas and enjoy my life. But Dr. Damayo, welcome. It's your turn. And truth be told, I met Paul. We were on a support group, and he told me, he says, before we talk any further, you have to watch Quiet Explosions. So I went and I watched Quiet Explosions. And Mark, a little bit of my background is I got diagnosed in 1999 with cognitive nerve damage at the age of 29. I also broke my neck. And with that, I've had issues ever since then, and even up to the point of having blackouts and having stuff. I further, in 2019, when we moved to Texas, 2014, finally a neurologist said, a year ago we wouldn't be able to diagnose you, but now we can. It's due to all the head hits and concussions you've taken riding rodeo and being a guy and bar fights and racing cars and boxing and karate and everything I did. And then I went on to 2019. I finally got the first suspected CTE on my neurological exam. And then in 2022, I got in a car wreck, hit a tree head on at 65 miles an hour, and it exacerbated my symptoms so far forward that I'm all messed up now. I have executive function, memory loss, vestibular, you name it, I got it. Suicidal ideologies, I got the whole ball and wax. And I actually went and Boston University, I'm part of their research and trials. I'm part of UCSF's research and trials. And Boston University sent me to the Glenn Briggs Institute for Alzheimer's Neurodegenerative Diseases at UT Health San Antonio. And I went through the CTE Evaluation Center, and I am diagnosed traumatic encephalopathy syndrome, probable CTE now. And so that's just a little bit of my background. We'll get into it later. Dr. Damayo, back to you. The reason why I brought all this around is because of Paul introducing me to you. I'm able to get on your genetic program and get on to the Mark Gordon protocol and get on all the supplements and everything. And it has helped tremendously. But my main question for you is, what got you involved into psychiatry? And then what brought you to the Mark Gordon protocol? Can you entice us on how you formed that relationship and alliance to bring you both here today?
Yeah. One thing I can say is that it was truly a blessing to meet Dr. Gordon, and it was actually introduced to me by my brother, Mike, who followed him and making sure this guy is a real deal. And then he heard Dr. Gordon was going to have this software that's going to help us do hormones. And I said, whoa, that's kind of cool. And the whole thing about treating traumatic brain injury patients, that's purely accidental because Dr. Gordon did more to teach me not just about hormones, but there's a connection between mental health, traumatic brain injury, and hormone replacement, which I never really come to appreciate. So learning about his hormone course is really totally ties into what I do. So adding that as the final piece of my Brainwell program to help it come full circle. And I don't have exact figures, but I would say that, quite a few of my patients who do the Brainwell program or they don't, I would say they have 90% history of brain injury, mild or moderate. And then, sometimes they don't even realize it until I do a deep dive. And I helped Mark do his course last year. And what's astounding is that 10% of people diagnosed with bipolar disorder have had a brain injury. I think it's more, but just to give an example, like I think I sent Mark a story about this, but a patient came to me, treatment-resistant depression, given a diagnosis of bipolar disorder, and she's like, "Come on, Dr. Maya, do you think I'm bipolar?" I said, "Well, now that I understand you've had a brain injury and you were beat up as a baby, no, I'm not going to say that, because let you go through the program and let's see what happens." And she says, "When I'm stressed, I get manic and I do all these things." And she did the program within 30, 60, 90 days into it. She came upon a really stressful situation and she was like, "I didn't get manic. I handled it. I was able to get through it." So in a way, I feel like sometimes I just want to throw away the DSM because it's like, it's just syndrome. And then like we were taught, this is how we diagnose and these are the things we use to treat it. And then like, you're going to find that right medicine. Well, 10 years of practice in this kind of care, I really come to realize that it's really just a farce, unfortunately. And, going back to Dr. Gordon's protocol, it's 28 biomarkers of the neuroendocrine system. So when people hear that I do hormone replacement, "Oh, you're going to give me my T," I'm like, no, that's not what I do. And that's not what Dr. Gordon taught me. I learned a concept of neurosteroids. I didn't even know that was a thing. These are hormones that have effect in the brain. Knowing that there are testosterone receptors in the brain, I was like, I had no clue. So this is why you can understand why hormones can play a big part in someone's depression. So I've been doing this protocol for about 3 years, so I can really attest to the program being the real deal. And what I see is that the results are long lasting. And these patients have come to me, they've struggled since their childhood and not realizing they may have had a brain injury, but I get this history of abuse, bullying, and all kinds of things that can cause brain injury. And so some of these patients that have completed the program 2 or 3 years later, no relapse in depression, they're functioning, participating, enjoying life. And what's really rewarding is actually to hear from the loved ones of these patients that I have my wife back, I have my husband back, my dad is back, and my mom is back to their old self. So the result of it is that patients who complete the program, 3 situations happen. They're not on psych meds. They never were on psych meds because we found out what was going on along. They're in the process of weaning their meds and no relapse in their depression, anxiety, or PTSD, or whatever it is that they came to me. And maybe the meds are finally working for the first time. And because I'm not against psychiatric meds, but I had to go outside the box to figure out why some of my patients are not responding to treatment. But I really like to share some of the results or some of the comments that my patients say that, I've never felt this good in my life. Or for the first time, I'm actually feeling good. And to be honest, I never even got those comments from doing standard psychiatric treatment. So what I want to talk about is like, before I got to this in terms of where I came from and to how I wound up with the Brainwell program, I just want to talk about my own journey and that how my journey gave me the framework for what is it that I came up with in the Brainwell program. I was actually trained in my first year residency, internal medicine and psychiatry. And then so I went into being a doctor that, okay, I'm going to be primary and internist, but a little bit of psychiatric background. So I know how to treat these depression and anxiety. But then I realized that I really loved psychiatry. It gave me the luxury to like spend time with my patients, hear their story, listen to their struggles, and know what their hopes and dreams are about. So after that, though, after 10 years of doing it that way, I've come to realize that, like, what am I doing? My patients are not getting any better. I keep switching their meds because they quit working or they're having side effects. And one of the worst side effects is suicide. And it was already in 2004, the FDA went ahead and put a black box warning that antidepressants cause suicide. And the latest study shows in 2022, they really want to say that it really does affect the children more, in meaning that kids on antidepressants have higher risk of suicide than the kids that don't have it. And the PDR, it says there, which is the physician's desk reference, the Bible that we learn all like the medicines and how to prescribe them. Short-term use, meaning once the patient's no longer depressed, we should start taking it away. But there's always that fear that if we take it away, maybe they'll relapse. But the truth of the matter is they're gonna relapse. And then I did a little bit of digging, and even before the things that I found today, even like a couple of years back when I was learning about all this, there is a 30% chance of treatment resistance just for depression. That's from National NIH. But what I really wanted to dig into is the STAR*D study. I'm sure, Mark, you've heard of that, but this is like the mother of all like antidepressant study, like 40 centers across the United States. And they had went through a protocol recommendations how to treat depression. And even after 4 medications, at that time, it was a 50% failure rate. But they reanalyzed it 2 years ago. It really is 65% failure after 4 medications. So what do we do with that? And if you want to do raw numbers, it's really 10 million Americans in this country that struggle with treatment-resistant depression. And even anxiety and OCD, in general, it is 50%. And bipolar, mainly the depressive state, 66% don't respond to your first psychiatric treatment. Why? I think we've been looking at this wrong all along. So psychiatric symptoms are not about how you feel.
Can I interject something?
Yeah.
What they found in a study in 2017 out of England is that 61% of treatment-resistant depression or atypical depression was found in people who had growth hormone deficiency. 61% of the cases had growth hormone deficiency. And when you fix the growth hormone issue, in 1 to 2 months, their depression improved or disappeared. So back to the hormones and the inflammation.
Yeah, and so that's, I always knew hormones played a part in why my patients didn't respond to my treatment. I just didn't know how to go about doing that. So I'm kind of glad that I found the Millennium Protocol. But in the end of it all, there's a new theory behind depression. And then we can talk about, oh yeah, it's hereditary, it's trauma. But where is the connection between those two? How does it affect the brain? That I had no clue. I was just told, treat the symptoms and, good luck. But I'm not satisfied. I'm a perfectionist. I want my patients to live their best. And so this is what I found with neuropsychiatric illness, is that it really is a chemical change in the brain triggered by stress that increases cortisol, that increases fractalkine that triggers inflammation. And you're like, okay, what does that mean? Well, in a nutshell, it disrupts your entire neurotransmitter balance. It decreases serotonin, dopamine, norepinephrine, and it decreases GABA. So no wonder people who are depressed, they have anxiousness, people who have post-traumatic stress disorder, they have anxiety, they have hyperness. And then that's not the only thing that happens with your neurotransmitters, glutamate. And I'm sure Dr. Gordon can talk about glutamate, but in relations to psychiatry, it is excitatory. It triggers anxiety. So you got low GABA, which is supposed to be anti-anxiety, and you got this glutamate. So guess what's happening? So I no longer look at my patient and blame them that, like maybe they're just not trying hard enough. Maybe they just don't believe in it. It's like you're dealing with chemical reactions that does not get better until you work on decreasing inflammation. So what I wanted to just also stress is that Mark was the final piece of the Brainwell program that I didn't even know that I needed to know. But I'm very grateful and blessed because I could have learned hormones from somebody else, but he's the only one that tied brain injury, hormones, inflammation, mental health issues. Oh, like, whoa, that's really like phenomenal because it's like that's not something that we are taught in our training. But I really had to go outside the box because, yeah, as you can see, more than 50% of patients do not respond to treatment. So what do I do with the other 50%? I'm like, I really want to help my patients get them there all the way to the end. So, before I even met Mark, so I had to go to this journey, like, how do I get my patients better? So I dabbled in genetics, but the way I was taught was like, no, this is not working. Until I really understood the pharmacodynamic piece of like what patients are made of. And I'm just going to pick on the three that I normally look at. I do look at others, but the gene MTHFR, which makes serotonin, dopamine, norepinephrine. There's people that are almost 70% deficient in that. So imagine if they're going through stress and you're already low in your serotonin, dopamine, norepinephrine. So if you don't address the genetic piece, then there's a problem. And then the dopamine gene, which depending was high or low, if it's high, I tend to call that the ADHD gene. So your dopamine runs low. And then if your dopamine runs too high, no wonder you have anxiety, obsessive compulsive disorder, low frustration tolerance. But the most important thing to understand with traumatic brain injury is the BDNF gene. There's probably one of the reasons why some people don't recover from a brain injury as well as others if they do not have enough ability to make brain-derived neurotropic factor, which is the fertilizer of the brain that helps in making brain cells and making connections. So, Mark just did Joe Rogan. He was talking about BDNF, and there's different ways to go about increasing it. And there's like peptides, but then there's also lifestyle things that you can do. So that kind of segues into like the integrative medicine for mental health, because it's like, okay, I wasn't getting anywhere with genetics. Let me move on to, learning about what supplements to give. And Dr. Amen kind of like opened me to the idea that it's not about mental health, but it's about brain health. And what can we do to support that? But even then, throwing a bunch of supplements on my patients, it just did not get there because it's like I wasn't correlating all of those things. And then I added TMS, which is really good for brain injury. And I really appreciate the fact that they had that in Quiet Explosion and they used that to treat these athletes. And what I found out later was that it does increase brain-derived neurotropic factor. So, and then also there's a new theory about like mental health and the brain energy, that if your brain is not producing ATP, nothing is going to happen to help you get better. And then final piece was the hormones. And I repeat this to all my patients, Mark, this is your quote. It is not treatment-resistant depression until you look at the hormones. And you're right. You know, I mean, I could bang my head trying to figure out what's wrong with these patients, but like, you know, it used to be where women come in and before I knew it, how to treat them with hormones, the natural way, the right way, you know, they do complain of like brain fog and they can't remember things. And I'm like, well, it's your hormones, but I don't know what to do with that. Here's some Prozac to help you with your anxiety. But I am blessed to say, you know what, I've got another option. And it doesn't include men's. And, you know, it's really, really fun to hear the patients like say that, you know, like, oh, thank God. So anyways, what I, you know, I want to just like, you know, segue into this, that you can treat the depression, anxiety, insomnia, dementia, but if you're not looking at the root cause, which is really understanding, addressing the inflammation and fixing the hormones, and you know, in the meanwhile, while we work on healing the brain so the hormones will finally work right, you ain't getting anywhere. And then what I do want to say, you know, with Paul, like his hormones have gotten better, have improved. And guess what? Mark, you're the only one that can say that, look, we don't have to do shots. And Paul is a testimony of that. And most people think that's the way to do hormones, but no, this is outside the box thinking. I'm glad because because sometimes when, you know, as you say, Mark, that you will do more damage than good. And you don't understand how many patients that came to me after their previous doctor done that damage, and I have to walk back and I have to just educate them. You're gonna have to trust me on this. This is the problem, you know. Just one more case I want to talk about. That there's a patient that came that he basically had a meltdown, didn't sleep, anxiety, panic attacks, and then I found out he was on like a high dose of TRT, shut off the brain hormones, luteinizing, and the you know, follicular stimulating hormone. But I didn't know, is this brain injury or not? Because his T was like this. Well, got him off a month later. Guess what? Brain injury. His T was down to 200. LH and FSH was still low. So what does that say? You know, we have to get people at their baseline, because if we don't know what we're dealing with, then how are we going to approach the treatment? But good news is there is hope, and there is a way to do psychiatry with long-lasting results that some people have not even found, but also to say that they've actually, just to say they're 20, 30% better is better saying, I have no response. And I'm always telling patients, you know, give it time. You're going to be what you are, what you want to be. So thank you, Mark, for helping me and encourage me and working with me for that. And couldn't get the results.
Well, you've got the results now. So the question is, of your population that have gone into the Millennium Protocol, not the Mark Gordon Protocol, but the Millennium Protocol, what percentage of them that you tested were found to be hormonally deficient?
I would say 100%.
100%,
you know,
yeah.
Well,
ideal.
Yeah, because, well, the thing is, before I even tell them, you know, this is your problem, I screen them, because I was like, you know, I don't want to just tell patients to do unnecessary things. You know,
and do you have patients that say to you, Doc, I came here for depression. Why are you doing blood work on hormones? You know, why are you doing this side thing? But it's not. And this is what the awareness needs to be promoted out there, is the fact that when you have an injury, okay, remember, stress generates the same abnormal chemistry in the brain, which Dr. Damayo was talking about. Cortisol goes up, fractalkine goes down, and you start dumping inflammatory chemistry into the brain. That inflammatory chemistry in the brain shuts down the enzyme systems that allow for all the neurotransmitters to be made. It allows for the neuroreceptors to be made, and it generates some nasty chemicals, peroxynitrite being one of them, which leads to Parkinson's. It leads to sleep deprivation syndrome because it shuts off melatonin, it shuts off serotonin production, and makes a chemical in the brain that listeners may not have ever heard of called kynureninic acid, which is, according to studies out of Japan with Dr. Takamura, talks about it being the cause for what we perceive is MDD, which is the major depressive disorder. And you fix this paradigm and you see people getting better. And the paradigm isn't fixed with psychotropic medication. It's fixed by addressing free radicals and inflammatory cytokines, by modulating the pathways that create inflammation in the brain. And I know you two are probably on some form of anti-inflammatory products, whether or not it's, things like vitamin D, which is incredible at fixing the brain. And you need to have good levels, therapeutic levels, not levels that are just within the parameter of being, okay, you need between 10 and 100 to be within the normal range. You're at 11, you're normal. But that's not the therapeutic level. You need to bring it all the way up to the other end. And so what we've found over the past 30 years is that for the average case of traumatic brain injury, mild psychiatric related issues, taking them to the 50th to 75th percentile of the hormone range is where we get the benefits. And in people with neurodegenerative disease like multiple sclerosis, Parkinson's disease, Alzheimer's and ALS, you need to get to the 75th to 100th percentile. What does that mean? It means that when your listeners go and look at their laboratory results, they'll take the low end and the high end, add it together and divide it by 2, and it'll give them a number of 50, that's the 50th percentile. So they look at their results and say, are we at that 50% or above it? They should be at it or above it for optimal benefits of hormones. Okay, it's like putting in a tablespoon of gasoline in your car when you're thinking of driving from Miami to Destin, to the Panhandle. You ain't going to make it. You're not going to make it. You need to have adequate amount of fuel in the car to get up there. You need to have an adequate or optimal amount of hormones in the brain. And when we have inflammation, the regulatory system in the brain, the hypothalamus, which controls the pituitary, the master gland, it stops working. So you lose the FSH and you lose the luteinizing hormone, so you can't generate it. But there's an order in which we lose our hormones, growth hormone being 1, testosterone estradiol 2, thyroid 3, and 4th is cortisol, which we rarely lose it. We usually get a lot of it at the beginning. And we only lose it after the adrenal glands burn out from fatigue, from being sick for such a long time, for being stressed for such a long time. But anyway.
Welcome to the Headrush podcast, brought to you by the Patrick Risha CTE Awareness Foundation. Karen Siegel, thank you so much. Paul?
So go to stopcte.org, learn about their foundation, and they are sponsoring us for the next year. We are thrilled to have them, team up with them and bring awareness to this disease.
So please go to their Facebook page, go to their website, check them out. Karen is very, very, very willing to work with you. Contact her, and if you do know her, thank her for us, or just go on their Facebook page and say thank you for sponsoring the Headrush podcast. So I got a question for both of you then.
Ladies first.
I'm going to turf that to you if I can't answer it.
Okay.
I've been through the TES. I've had a PET scan to check my amyloid. I'm negative on amyloid, and which helps get to that TES diagnosis. And I just started the Millennium Protocol.
Mm-hmm.
And I'm about ready to take my second blood test come next month. In February, I'm due to take mine and then meet with Damayo in March. I've already noticed with my other doctors that when I have my testosterone after the wreck and after everything dived below 100. And it was low below that, but below 100. And so they had me on, I was doing 1 cc a week. And it's amazing. Even my urologist, and like I say, it takes a village to keep me halfway sane. It's like I have the right hand shakes right now. That's why I'm sitting on my hand, because my hand's shaking. So I'm as close as you can get to being diagnosed CTE and the Living with TES endorsement. With the 28 blood panel, I know that the pregnenolone itself and the vitamin Ds and the 5-HTP and all of this, you know what my testosterone levels boosted up to was over 1,400 with the once a week shot. So they've lowered me down to 3/4. Now they lowered me down to a half of testosterone, because that pregnenolone and everything else, I think, is what's getting me back up to my levels that the doctors are actually saying, no, we need to cut this testosterone shot down.
Yes.
And I'm on galantamine, I'm on memetine, I'm on all this other stuff. But I'm noticing a change. And even my wife said it the other day, that when was the last time you had your rage and went into the back room that I call the cave? That when I'm pissed,
Yeah.
I take off to the room and everyone knows to leave me alone, because I can go 0 to 100 in like now. And so I'm a firm believer in all these supplements. But my question to both of you is, and when me and you were messaging, Mark Gordon, you said when you want to talk about your, in your words, regulate my disease. That being said, with my vestibular, my coordination, my central nerve system damage, can it be regulated, slowed down, or are you saying that, and I'm going to hate to use this word, fixed? Can I get, I got atrophy in the, I got atrophy in the brain already.
Modified, adjusted, choose a synonym. Okay, all right, choose a, yeah.
Right, I mean, but I got atrophy in the brain already.
Yeah.
I got all that. So with this protocol.
Yeah, well, what I'm hearing from you is not that you're cognitively impaired. I think someone's trying to, make you think you're cognitively impaired. Your question was very, appropriate, and, you've been appropriate throughout. But to answer the question more specifically, the total testosterone level is garbage, simply garbage. Because if you ask a doctor, you talk about total testosterone, tell me everything that makes up total testosterone. And they'll look around, they say, free testosterone. Aha, that's the key. Free testosterone, the rest of it is epitestosterone, dihydrotestosterone, what else is in there? Protein-bound testosterone, albumin-bound testosterone, cortisol-bound testosterone, sex hormone-binding globulin-bound testosterone. These are all different forms. And the question is, which ones are readily available that can go right into the brain to correct the brain? It's the reason why I don't use any topical testosterones, because you put topical testosterone on the skin, 70% of it converts to dihydrotestosterone, which gets stuck below the neck. So it doesn't go into the brain. So we should be only looking at the free testosterone. Who cares about the total testosterone? It's the free testosterone. And looking at the free testosterone, you look at your estradiol, you look at your sex hormone binding globulin, and you look very, very closely at the dihydrotestosterone, because dihydrotestosterone will cause your liver to produce more sex hormone binding globulin, and that will bind your free testosterone. You don't want to bind up your free testosterone. You want it to go right into the brain. It is the form of testosterone that gets passively transported into the brain, where DHT can't get in. Okay? DHT is made in the brain. And we know from studies from the 80s to now that if you're on DHT, instead of taking testosterone, you can take things like nandrolone decoinate. There's a whole bunch of group of anabolic steroids that look like DHT that work wonderfully well for muscle growth, but doesn't go into the brain and creates all the problems. They used to call it, and I apologize, DECA-DIC, which meant libido-related issues if you're on nandrolone decaonate or one of the they call it congeners, one of the chemical structures that look similar to DHT. So in your situation of going up and down, and as well as giving you 200 milligrams in one shot, is wrong. You should separate the injections, because this is what happens. He's probably using, or you're probably using, testosterone cypionate, correct?
Yeah.
And testosterone cypionate takes about 36 hours to get into the system. We developed in 2002 blended testosterone, which uses propionate and cypionate. And the benefit is that the propionate gets into the brain in 1 to 2 hours. And then the cypionate takes 36 hours to back it up. So what happens is the testosterone, when you give a shot of 200 milligrams, 1 cc is 200 milligrams, you get this huge spike. And what does that huge spike do? Your body says, wait a second, you've just overloaded me at one shot with testosterone. I got to get rid of this stuff. So what does it convert it to? It converts it to DHT and estradiol. Now, you can manipulate the DHT safely with selenium. You can manipulate not getting estradiol with zinc. So there are ways to modulate it. But the body says, hey, too much, too much. And the only reason why estradiol goes up is because the body has diverted some of that injected testosterone into estradiol. And then they put you on a drug called anastrozole or arimidex, which is a toxic chemical to 8 systems in the body. 1, 2, 3, 4, 8 systems. So it is important for neuroplasticity, memory recall, and the ability to learn new things in the hippocampus. Very important. It's important for helping you generate your own growth hormone. It's important for blood flow in the brain, which is through something called endothionitric oxide synthetase. So it helps blood vessels dilate. And it's important for libido. That's above the neck. Below the neck, estradiol and growth hormone in the liver turns on IGF-1, insulin-like growth factor, which is the main below the neck growth factor, which improves muscle repair, cellular growth, or cellular repair, tissue repair, organ repair. It helps with protein synthesis at the ribosome. So you make enzymes, you make your antibodies, you make all the chemistry from protein. And then it protects the lining of the arteries, the intima. It helps heal it. In studies done on low growth hormone, you see accelerated heart disease. 33%, according to a Scandinavian study, a 33% increased risk of heart attack and death. And then the last one is protection of the heart and the bones. So these are the benefits of estradiol. That's why I don't touch it. I don't care if the estradiol is elevated. And I ask them, well, your estradiol is elevated. Do you feel that it's creating a problem? And they say either no, or they say, maybe I'm a little more emotional. Bullshit. Okay. Fluid retention, yes. But they've got such great levels of testosterone that counters any of the side effects of estradiol. It's just they've been mentally and on the internet told that, oh, elevated as an isolated discussion, elevated estradiol creates problems. So what you need to do is you need to divide your doses into every 72 hours, as we've been doing since 2014. Before that, we gave 60 milligrams of our blended testosterone every Sunday. 70% of the people did very well. There were 30% that had an early drop-off. So we went to every 72 hours, and you don't get the spike, and you get consistent level of testosterone. Consistent level. Right now, you spike up, you produce estradiol and a DHT, and then in 7 to 10 days, your level's back down. So where's the benefit? You get problems and go on anastrozole, which you just acknowledged you're on. Poison. Go look at the side effects of anastrozole. I have major portfolio on it with depression, cognitive impairment, vascular related issues. It's not a safe drug. And the only reason why you're getting it is because you're being overdosed on testosterone. That's it. And your body is different than my body. I only need 60 milligrams a week. There are other people that need 100. But the majority of our patients get 80 to 100 milligrams a week, split up so they don't spike. No benefit from spike. You spike and your body kicks in. Hey, too much. Let's get rid of it. So it's waste. It's like drinking a good bottle of scotch at one sitting. You get messed up, but you run out of scotch.
That's really we can talk about testosterone all day, but like the whole point of the Millennium Protocol is to analyze what your levels are before it becomes testosterone. Maybe we can try to help you create those things in a natural way, because if we just give you tea and then you shut off your brain hormones, you are missing the benefit of pregnenolone, which is important for me in mental health, because pregnenolone gets low in traumatic brain injury, inflammation, and menopause, premenopause. And so now I know the answer to these questions of, female patients ask me, or even males too, that why am I not remembering things? Why I can't sleep? Why I'm anxious? Why I can't stay asleep? And standard hormone treatment fails to really look at that. And then, so they're missing out all the benefits of pregnenolone, which, number one, increases GABA in the brain. And number two, this is like, I think, one of the first interactions I had with Mark, through Zoom, and he just opened my eyes going, that allopregnenolone eats up amyloid plaques in the brain. And doing a little bit more research is that why is it women are more prone to those chemical changes in the brain? It's because, we're so used to the pregnenolone once it goes down, because, your body says like you don't need it anymore. But we now have discovered that there are mental health benefits to the pre-hormones before you get to testosterone, estrogen, and progesterone. And this is only through the Millennium Protocol that I learned the value of that. And so, when Corey was talking about pregnenolone, how it's calmed him down, or like he notices he's not having these rages. And really, it's because the pregnenolone was nowhere, because you were being dosed with too much testosterone. And then your brain said, well, I don't need to make anything because you're giving that to me.
I think so Quiet Explosions was my introduction to all of this. And I had been involved with clinical trials and trying to find CTE biomarkers, 10 years ago. I see Quiet Explosions 2.5, 3 years ago, and I hear you, Mark, talk about pregnenolone probably 5 times in the first 10 minutes of that movie. And you were talking about pregnenolone and DHEA, and you and Andrew Marr had the similar experience of some of the servicemen and women hearing that, pregnenolone, it can help. And here, first of all, now hearing these two speak, Mizyl and Mark, why my eyes were glazed over, after 30% of the seeing the 8-hour presentation, but it was an eye opener. It was just fascinating to see. Oh, you don't have to take a shot of testosterone. You can naturally have a positive effect on through this and this. That's what you want to start off. I wanted to start off first with those natural possibilities, because I wasn't a big drug guy. And then another comment you made in Quiet Explosions, you said one brain trauma, one head trauma, and I didn't know this either, that it doesn't have to be a bump on the head and a blow to the head. It can be just a rape, just a terrible experience, in childhood, or so on and so forth. But one,
losing your son.
losing my son, death in the family, losing a son, exactly. But one incident like that could actually change your personality. Within 1 year, you can be a totally different person, whether it's the anger, the rage, or so on. You know, at 47 years old, my everything flatlined and something happened, and I knew something was going on. But and I was very blessed to attend one of your lectures, and you actually put me on your Sunday list. And we get articles every Sunday. You send out articles, medical journals, not peer-reviewed, not just fake, real science, peer-reviewed stuff. And you were talking about Mizyl's project of, you know, mental health and just the psychiatry. One blow to the head can change your mental health persona. And then one of your articles that you sent, it was a neuroinflammation and neuropsychiatric disorders, or an effect on neuropsychiatric disorders. And last thing I'll mention, and I want you to respond to it. You told me one of the first times that I was able to speak with you after I was stalking you at the conference. You said, well, Paul, because, you know, CTE as a 20-year organized football player, that would be my concern because, and you said, well, CTE, Alzheimer's, Parkinson's, ALS, it's the inflammation, Paul. And I'm like, it caused me to start looking at it from a different angle. It's the inflammation. Oh, and then I started learning after your last subconcussive hit, or your head trauma, or the inflammatory cytokines, and I'm probably getting this wrong, but I believe inflammation can be detected in your brain up to 17 years. I believe.
You got it.
Yeah.
Absolutely.
So
that's what the literature talks about repetitively. Yes. So, you know, the issue is we're spending all our time looking at end-stage terminology. CTE, depression, anxiety, bipolar, Parkinson's, ALS, Alzheimer's disease, dementia, migraines, seizure disorder. They're all relative to the inflammatory process. I learned, honestly speaking, last year, 23 was last year for me. In 23, that 30% of the people who develop multiple sclerosis have a history of traumatic brain injury. Okay. How did I learn that? Well, we had a Navy lieutenant, and you can see his video on our YouTube channel. You might have seen the one about multiple sclerosis and neuroinflammation. Oh, here's a guy who is Navy lieutenant. He was in charge or worked with the nuclear power plant on one of our carriers. And he retires in 2020. And between 2020 and 2023, he develops loss of vision in his left eye, weakness in his right hand and right leg, hallucinating, cognitive impairment, personality change, and so forth. And he gets a diagnosis in Florida of being multiple sclerosis. As he's leaving his appointment at the VA with his new diagnosis of multiple sclerosis, which he already had a feeling about because he did the research on treatment. He's a smart guy. Tim's a smart guy. And he saw the benefits and risk factors of standard treatment for multiple sclerosis, and he decided not to. He told the VA, I don't want to go on this stuff. And as he's driving home from the VA, he turns on his favorite radio show, Joe Rogan. At the moment, I'm talking about a Navy SEAL. This is God's intervention, you know? And the Navy SEAL that I was talking about, Nathan, who was 50% better in 60 days. Tim sends in a request. The next day I'm on the phone with him. As you know, I call every one of our military, whether or not active or veteran, Coast Guard, or National Guard. I call them all, and I have a 15 to some of them an hour-long conversation. And we had a conversation. He comes into the program August of 2023. In 1 month, he's 50% better. In 3 months, he's 90% better. And then we put him onto a peptide to help embellish his brain repair because of brain-derived neurotrophic factor. And he's 100% better. 11 months in total, 11 months from when he was 100% better, 11 months with no medication and still in remission. Okay, so he's number 6. We've got number 7 who just came in. This is an inflammatory process. And Tim had 2 head traumas with loss of consciousness. Okay, and then I'm just rewriting a presentation I did in October in Utah on Alzheimer's disease, understanding a hormonal approach to treatment. As Dr. Damayo was saying, pregnenolone has incredible benefits in the brain. It's anti-inflammatory, free radical scavenging. It's neurostimulating. It helps with neurons to communicate, called synaptogenesis. And on the other side of the coin, it increases GABA. I had a Marine come into my office when I had a brick and mortar, and I'm looking at his lab results. Okay, so I'm seeing his lab results, and I say to him, okay, so how many hours do you sleep in bed? How many hours are you in bed? He said 13 hours. I said, damn, you must wake up in the morning feeling great. He said, on the contrary, I wake up feeling like I never put my head on the pillow. That's what I was waiting for him to say, because his pregnenolone level and progesterone levels were 0. It should have been 80 to 100 on the pregnenolone and 1 on the progesterone. And why is that important? Because pregnenolone becomes progesterone. Progesterone becomes allopregnanolone. This chemical allopregnanolone, about 8 years ago, became a pharmaceutical product for $34,000 a year. Its simple name is called brexanolone. I won't tell you the proprietary name, the sale name on it, because I always say it wrong. So it's brexanolone, which is their new name for allopregnanolone. It's the same thing. Our allopregnanolone, our pregnenolone to become allopregnanolone is $80 a year. The brexanolone is $34,000 a year. That's for just the medication. You have to go into the hospital for 30 hours every month to get an IV infusion of it. It was developed for postpartum depression and has effect on depression and anxiety. And they haven't even started talking about the benefits in sleep. It helps as a side effect sleep because pregnenolone stimulates GABA, the natural volume of the brain. So a long story about the importance of pregnenolone. And as Dr. Damayo said, I really use injectable testosterone these days. What we do in the Millennium Protocol is we first start by trying to reinvigorate, correct the problems that caused your deficiency. You know, the question isn't being asked, okay, guy's got CTE. Aside from telling me it's from head trauma, biochemically, why? I work at a molecular chemical level. So when you have trauma, I see the pathways of inflammation causing calmodulin to change, causing the receptors to change, causing you to produce more CTE chemical called NFTs, which is the neurofibril tangles, which comes from the hyperphosphorylation of tau protein. What does tau protein do? Tau protein holds what we call microtubules in the neurons. What is the microtubule? That's the passage canal for sending down neurotransmitters. So the reason why and it's more specifically acetylcholine that gets affected. So growth hormone can rebuild those neurotubules, but you'll see a couple of articles on it, but you won't hear anybody talk about it. So this is part of how we've been able to reverse the dementia part of Alzheimer's. And there's our oldest patient is 95, and he's a Korean War veteran. He came to us through his son, who I work with in Florida, which is a great team. They have ancillary services for the military, HBOT, I think red light, and some of the electroneural technologies. And he called me and he said, do you have anything to help with dementia? My dad's got dementia. I said, sure. So I sent him a kit. And 70 days later he calls me, says, my dad's dementia is almost gone. I said, oh, that's interesting. Let's get on a Skype. So we get on a Skype and he's talking, he sounds good. And we get into a conversation. He was a PhD in child and adolescent development. So 2 of my 3 daughters were getting ready to give birth in August of 23. And we talked about that, and he was crystal clear. And then at 90 days, the son sends me a 1.5 minute video, which you can see online on the YouTube channel. And then at 180 days on protocol, they sent me another video where Edward Riebach was on a program talking about he runs a mile every morning. He's in the gym 3 days a week, and his word acquisition, his word skills, his sentence structure, his delivery, his poise was just unbelievable. He's now 95, and we ended up having in October of last year it was supposed to be a half an hour conversation. It was over an hour. We're just talking about everything, and my questions were to challenge him to see how, and he was unbelievable. I mean, so that video is also on the website as one video. It's 3 minutes long, something that people might like to see. But the point is, you want to know why you're deficient, not just to give you testosterone. You want to listen to the history. And you don't want to do this knee jerk of everybody gets on testosterone because, as Dr. Damayo said, once you put them on testosterone, it shuts down their natural production. And when you put someone on testosterone or a woman on estradiol and testosterone, it shuts off their own brain's ability to make 35 hormones. The two most important ones are DHEA and pregnenolone. So any one of our patients on protocol gets DHEA and pregnenolone. And the DHEA is not taken in the morning like most doctors give. It's taken after dinner. Why? The added benefit of DHEA at that time is it increases growth hormone production. The pregnenolone you take after dinner because by the time you're ready to go to bed, it generates GABA, so you sleep really well. So the guy that had 13 hours and wasn't sleeping, he felt like he didn't put his head on the pillow, 2 weeks later on 100 milligrams of pregnenolone, 15 to 30 minutes after dinner, he's sleeping like a baby. I've lost more cases, not really. I've lost more active clients by pregnenolone and DHEA. And that's why with the Marines in 2020, we developed the phase 2 protocol, which is what we have about 7,000 plus people that don't come to us for laboratory work. They go on this protocol that they can acquire through the website. And it's inexpensive and they don't need it for life. But it's the combination of vitamin D, DHEA, pregnenolone, and some nutraceutical anti-inflammatory products. And that's the key.
My main protocol with my patients that we don't need. And then there's times where I may give temporarily the hormone creams based on what it says in your protocol. But I'm able to get those women off those creams in 6 to 9 months. And they're so thankful. And when you talk about losing clients, to me, I tell my patients, I will be happy if you don't need me anymore. Because you can buy these things over the counter, come back and see me once a year so we can look at your hormones again, or call me if you're struggling and, we'll look at it again. But right now, like I said, there's 10 million Americans just struggling with depression alone because they're not responding to standard psychiatric treatment. Got a lot of work to do. So yeah, we really do need to have a whole army of people doing the protocol, or people that are capable of doing it, because there's so much people out there suffering. And it's a blessing actually to sit here with you. And I don't even know how I wound up here. Okay. I guess I have to thank my brother, Mike. I told him he needed to be here, but just this little story about like how good of a man Mark is. I mean, like, we bought your program. I was like, oh great, I want to learn about hormones. And I was like, I need to know this. And I think Mike sent you an email. I mean, like, he's incredible. Like, he goes through every email and he'll call. And like, all of a sudden, like, Mike sent you an email, and then I overheard somebody talk. He was talking to someone. I figured it was somebody from your company. And then he comes back. I think you guys talked like 2 hours, and he called, and it was Dr. Gordon calling. I'm like, what? He's calling our little practice here in Punta Gorda, and I was like, wow. So it's been a great, awesome journey. But it's not so much that I know how to treat patients. I just really want to get the word out. There is a better way to do psychiatry, especially if you're struggling. And, even standard study shows for medications and you still don't respond, you got to do something different, right?
Yeah.
So thank you for bringing me here because that's what I really want to do. It's more of a mission. And to me, the absolute results I get that I've never had with just prescribing medications, that is rewarding enough. So thank you all for giving me the opportunity to share.
Ladies and gentlemen, welcome to Paradise Behavioral Health in Punta Gorda, Florida. Dr. Damayo is sponsoring this episode of Headrush, and she deals with...
She's a doctor of psychiatry, and she has the Paradise Behavioral Health and the Brainwell program, and which we're both on. So we're very excited to have Dr. Mizyl Damayo as a sponsor for the next 10 or 11 months, right?
Right.
So it's awesome to have them on board, and thank you very much. And definitely go to their website, learn about what they do, learn about they call it precision psychiatry, and she's right for anything that ails you. So go check them out on the web, Paradise Behavioral Health, and look for the Brainwell program.
And she also deals with the Millennium Health Protocol and the hormones that me and Paul both are part of. So go check them out. Thank you, Mizyl. You're awesome.
Well,
this is a perfect lead into, because you just mentioned it. Let's get into my records.
Oh,
I'm an
okay.
open book. So I'm looking at the Millennium Protocol right now, my lab results.
Okay.
And like I said, I just started. You mentioned pregnenolone.
Mhm.
I'm at 6.7%.
Yeah.
You
And what's
mentioned
the range of your 6.7%?
Yes.
Okay.
Percentile.
Let me clarify something. The reason why we give pregnenolone is so that you can generate progesterone. So we have people who are at low percentiles of pregnenolone, but their progesterone levels have been pushed up. That's it. So if you can come back and say you have a 0.8 or a 1 on your progesterone, we're good, regardless of what your pregnenolone is.
My progesterone is 18.4.
And this is from the first blood draw, right?
This is from
Before
the
you
first
were
blood
on
draw.
protocol.
You're using Quest or LabCorp, not
LabCorp.
Access
I
Medical.
think it was,
You're-
LabCorp.
yeah.
Mhm.
So, I only use Access Medical because
Yeah.
that was the company that we helped to develop the entire 28-point biomarker. But any lab can work. You just need to look at the technology that they use.
Yeah.
So
sometimes-
what is
yeah.
the range? What's
Yeah.
the range on the progesterone?
I can look it up right now. Let me see.
It said low normal on mine. My growth
No.
hormone
What's the
is
range
Yeah.
that the laboratory gives you?
Yeah,
Right.
I can pull it up right now. Let me take a look at it.
Well, while she's pulling that up,
Yeah. Yeah, because otherwise the numbers don't mean anything to me.
right.
If
You
you can
don't-
tell me what the percentage is of the progesterone.
It's very rare that you have doctors that really concentrate on their patient, and then you throw in they actually care about their patient, and then you throw in a doctor that says, I want you to not be a patient anymore. We got to get you on the road to recovery. And that, did you find that information?
Yeah, it's actually less than 0.1. So you had none.
right.
So
Okay.
there wasn't any.
And that's your original ones?
Yes. This I haven't done my second.
Just tell
after
me the
protocol.
ones that you're at now. The original ones, I got it. You were
Yeah.
low.
Yeah.
Right. I haven't
Across the
done a
board.
second one yet. I do my second
okay.
one tomorrow.
Understood
I do
now.
my second one next
Sorry.
month because I just
All
started.
right. That will be the one to really take a look at because you've already said you've gotten better. So that means that inflammation has been addressed, hormonals have been addressed, but to what level?
Right. And so this
And they can
next
still
month
give you the CTE. They can still give you the CTE diagnosis, but you don't have to actuate on it. You don't have to respond to it.
right.
You know,
And that's
like I've got a flat tire, but I've got run flat tires, so who cares? You know.
And that's what I tell people on Hope. I said it takes a village, but I'm not relying just on medical. I'm going outside. I'm going for my hormones. I do vestibular therapy. I see another therapist because you mentioned how big, what I can't think of the word, regenerating the brain.
Plasticity.
Yeah.
Neuroplasticity.
The BDNF.
Okay.
Right. On how important that is. And it's like my vestibular therapist said that, yeah, you may lose a little bit at a time, but we can regain it and regain and losing. So for me, I look at it, I'm big. When I first got the diagnosis, I looked at what stage, how long do I got left to last? You know, when am I going to lose my mind? But you know what? I don't care about stages no more. I care about life. And I've said it on every episode that TES, suspected CTE, is not a death sentence at all. There's ways to go out. There's hope and help everywhere if you reach out. You know, I'm doing all the therapies. I'm doing the hormones. I'm doing the genetics. I'm going out and I'm reaching around. I'm not just going to rely on just one doctor. I rely on everybody to get me where I'm at. And like you told me about separating my testosterone, we're down to 100 now instead of 200 because of pregnenolone and everything I'm on. And we're talking how many months? This is the third month come February, right?
Yeah, it's not even that long.
Right.
Yeah.
And we've already
Good.
cut it down. So, I mean, there's hope out there, people. There's help. You just got to reach out and get it.
I think it's pretty fascinating. You said your Susan, your wife, just asked you the other day how many times. When was the last time you went into the cave, the room, to the pissed off mode? When was the last time you had to get away?
Yesterday morning, but
Well, have the occurrences diminished in the last few weeks?
oh, tremendously. I mean, it's yesterday morning. It's because she got in a hurry. We had to pick you up at the airport. She was vacuuming, trying to clean. All the noise got to me. I got overstimulated, and I just went. I got breathing on my phone. And so I do breathing techniques to just kind of calm myself down. And so I use these breathing techniques. My therapist taught me how to look at a picture, deep breathe, look at another picture, deep breathe, look at another picture, do it 5 times. And if you need to, repeat. Oh, and I got another breathing technique. So, I mean, there's help out there.
So that's what I wanted to focus on, the hope and the help, right? So Dr. Gordon, Mark, you mentioned, Alzheimer's, and some people are having, there's promising research going on of reversing or diminishing the symptoms. And I know at one of the AMG events, Dr. Bredesen was there, and I know it looked like you were very, very good friends with him. And when you talk about Alzheimer's, and he's had in his book that was released in 1999, I believe, he talks about, and I'm sorry, 2019. I think he talked about reversing clinically. He was reversing Alzheimer's symptoms. And when we get, Corey and I have had deep discussions. Corey, he's a strong, cowboy dude, and he's got his thoughts of, I'm here, and I'm not gonna. I'm never gonna get better, but can I stop it? Can I at least, regulate it? And you were talking about, when you want to talk about regulating, the symptoms of CTE or so on and so forth, come to me. Let's talk about it. I think that in my mind, the hope is, yeah, that would be really cool if we could stop it. and then maybe, reverse it a little bit. And
definitely. That's why you don't give up hope.
Well,
right.
And so let's not worry about my medical, Paul, if you don't mind, since I've only had one and I'm raw to all this. Just look at your differences.
Yeah.
But I mean, and while you're pulling it up, I'm just going to say, it's not a death sentence. You don't have to, I lost my aunt to multiple sclerosis years ago. And I got a real good, that my wife runs a equestrian club here in Fort Worth. And we have a member whose husband has Alzheimer's. And I've been talking to him about this and her, because he's well advanced, and saying, you need to look at some of this. UT, when I go down in October to get my next MRIs and neurological exam and all of that at UT in October, they're enrolling me into the Alzheimer's trials program. And I don't have amyloid, but they're just enrolling me into, not their trial, but just the research.
Gotcha. They're not going to give you one of their new anti-beta amyloid products that's not working.
No, because I don't have amyloid. So I'm good on that.
Yeah, you said you have no amyloid plaque.
Right.
So why are they putting you into an Alzheimer's project when you don't have any amyloid plaque? They used the PET scan to detect whether you had amyloid or not, right?
Right. And I have none. They're just putting, it's in the neurodegenerative, I guess, their research.
That's all inflammation.
Right.
It's like, we have all these neuroradiological procedures. We've got PET scan, we've got SPECT scans, we've got MRIs, we got DTI MRIs, we got all this MEG scans, we got these beautiful scans. Not a single one can show you inflammation. And that's
I thought the AMIC clinic in SPECT scan showed that.
Sorry,
I thought in the AMIC SPECT scan showed you inflammation. It don't?
Well, it's interesting. Daniel and I have had a conversation about just that. What you find in the SPECT scan, those punched out areas, are areas of low blood flow, because the injection you get is a radioactive isotope that piggybacks on the back of red blood cells that circulate through the brain. And when you see a nice smooth confluence of smoothness of color throughout the brain, it means that you've got perfect blood flow. But when you have an area where there's a deficiency or a defect, a visual defect, where you can see through the brain as opposed to seeing it nice colored green, whatever color it is, it indicates there's something going on with blood flow. So it happens from this inflammatory process. It generates peroxynitrite. And peroxynitrite steals nitric oxide from the blood vessels. Nitric oxide is the chemical that causes the blood vessels to stay open. So if you steal the nitric oxide, the blood vessels constrict and blood doesn't flow in there. And how do you know it? You see it as those punched out areas that Dr. Amen talks about on his SPECT scans. So is it inflammation? Yes, but it's more telling of a process of biochemical, molecular chemistry. It tells you more of a molecular chemical process that's going on that could be reversed.
Oh,
and
right
that
on.
reversal is by decreasing the production of peroxynitrite. It's from reactive oxygen species and nitric oxide coming together, and that's what makes peroxynitrite. So what do? You get rid of the reactive oxygen species. How do you do that? You make sure you have good free radical scavenging in the brain, whether or not it's EPA, DHA from fish oil, quercetin, vitamin C, glutathione, N-acetylcysteine. These are the keys. Vitamin D, estradiol, testosterone. We look at our hormones as being what? Sex hormones, reproductive hormones, masculine hormones. Well, it turns out that they have a multitude of functions that we call pleiotropic. One of the benefits of estradiol is that its molecular structure has something on the front of it that goes and destroys free radicals. Pregnenolone, progesterone, allopregnanolone destroys free radicals. testosterone goes in and stops 4 pro-inflammatory cytokines: interleukin 1, 1 beta, tumor necrosis factor alpha, and interleukin 6. It also stimulates the strongest anti-inflammatory cytokine called interleukin 10. So this is why we need to have great levels of estradiol in a male as well as in a female, and testosterone and pregnenolone and progesterone, so that we make the allopregnenolone. So that's how the hormones, not just the hormone to make you feel good, libido great, but testosterone, free testosterone is important for sense of well-being, aplomb, assertiveness, cognition, memory recall, the ability to learn new things, creativity, sleep, sex, all these things. Oh, and another one, Dr. Damayo was talking about her focus on depression and anxiety. What we found is on the lateral aspect of the amygdala, which is part of the limbic system, our emotional center, that if you're deficient in DHT, testosterone DHT, dihydrotestosterone, that you're more prone to being hypervigilant, panic, and startle response. So higher startle response. So, every little sound you're jumping or hypervigilant. And they found that testosterone reduces that. So we see it in our patients who have morning anxiety. They wake up, they have a panic attack, or afternoon, they have a panic attack, or whatever, randomly they have panic. And you look at their DHT levels, peripheral DHT, you look at their free testosterone, and you look at pregnenolone and their progesterone levels, they're all low. And when they come up to 50 to 75 percentile of the range, they're not as reactive as you just said. You're not as reactive. That's why.
I hate to say this, but we're coming down to, 2 hours goes by pretty quickly. And really quick, I know, Dr. Damayo, you have some of my blood work up. I was fascinated with the genetics. I knew the hormones was right on track, but I was fascinated with the genetics. And when, really quick, some of my my low BDNF, my brain does not repair as well as somebody else's brain who has a strong BDNF. I guess you would say, a low factor of BDNF. And then the low CompT and the MTHFR I was lacking.
Yeah, Paul.
Yeah, so
not even knowing anything about your struggles with mental health. I just looking at your genetics, I'm like, Paul, boy, you didn't have a chance.
Hey, Mark. I've got a really hard case here. Can you help?
The genetics are awesome, though, because of the drugs that my genetics shade don't take.
Mm-hmm.
My neurologist and all of them actually have, I take this to the doctors.
Mm-hmm.
I got my Brainwell program binder I take to the doctors with me.
This is the Bible, I guess.
It's my Bible. Right here, it's my Bible.
Amen.
And they go and they look at my genetics and they say, okay, we're not going to put you on this because of your genetics. We're not going to. So my doctors are working with Dr. Damayo, and they're all very inclusive.
And before they knew your genetics, they were happy to try a drug that wouldn't even work on you.
Right. I've never taken an SSRI. Thank God. I've never taken one, and I've never been down that rabbit hole.
Yeah, and that's exactly what, I don't know, Paul, I think, were you ever on like Zoloft, Prozac, or anything like that?
I was on that Wellbutrin one time, and it gave me heart palpitations.
Gee, I wonder why. So, this goes into the dopamine metabolism, but like, I love looking at people's genetics because it's never like what I think it is, and like, sometimes you have genetics that really work against you, and sometimes you have genetics that contradict each other, and that was Paul. Okay, so let's start with Paul in terms of his dopamine balance. In general, if his brain was functioning right, he tends to run kind of high in the dopamine, but then I can actually look at a genetic test and like I can guess what people's personalities are. And they're looking at me like, how did you know that, doc? It's like, well, it says so in your genes. So if you are a low dopamine metabolizer, you're prone to OCD, anxiety, and like low frustration tolerance because you run kind of high in dopamine. But then he has this conflicting thing where he has the MTHFR deficiency. Thank goodness it's only like 50%. So before I realized the connection between the two, when I started using genetics, I was throwing L-methylfolate in people and they're calling back, Doc, I don't like that. It's making me anxious. I'm like, why? It should have helped you, until I really read up about the dopamine gene and maybe you can, the enzyme, and maybe you can help me with this. And what's interesting about the dopamine enzyme, COMT, it also affects estrogen. So in my experience, Mark, I've seen it where like if I didn't know that about a patient, I was throwing, testosterone boosters and they'll call me back later on. And I'm like, I'm really anxious, doc. I was like, what's wrong? And I checked check back on their genetics when I finally get it back. And then I look at their like estrogen was just low before, and here it's great. But then they're complaining of anxiety as well. And I'm like, yeah, so it's a combination of you got to look at the genetics and you got to be careful in how you treat the hormones as well, because everything affects one or the other. So if you have MTHFR deficiency and you have low COMT, I think Corey, you're the same way.
Yeah,
so
I am. No wonder we're like brothers now.
Yeah, so brothers and genes. But like, so normally I don't even tell people sometimes to take L-methylfolate because it just throws them to a tizzy. And that's what it did for you. Right. I did warn you though. I said, if it does that, you better just stop it.
Yeah, within days, I called you back and I said, I'm really anxious, Doc. What's going on? What's happening? What low COMT? What does that mean? What's going on?
Yeah, and then
you said just stop taking the methylfolate, Paul.
Yeah, you'll be okay. So you treat like what you also taught me, Mark. Treat the patient, not the labs. Because there are some times when I have female patients that I give them too high of testosterone and they're feeling great, and I'm like, oh no, we need to back away. And then a week or two later, they're calling me going, I'm having menopause symptoms, I'm irritable and I'm depressed. And I'm like, oh, okay, so you need to stay on that higher dose of testosterone. And so it's really like a collaboration. I'm not here to dictate, you need to do this, you need to do that. I want to hear your response. And so that also, I didn't, broach it that way until Mark really took me under his wing and taught me all of his philosophy. I said, wow, okay, yeah, we need to listen to the patient.
I'll give you a quick testimony because we are really getting up against it. I had 2 strokes almost 7 years ago within 2 days, and I had a tremor in my hand, in my right hand, and my father had a tremor in his right hand. He's 89 years old. He's doing well cognitively, no dementia issues, but he has that shake, and now he can't even hold a cup of coffee. I went to the Mayo Clinic where I was serviced for my strokes, and I went to a movement specialist, and they said, no, it's not Parkinson's. I wanted to rule that out, but they said it was familial tremors. Don't you know, since within weeks of getting on the Millennium and Damayo Brainwell program, my tremors went away. And I'm like, okay, that's cool. So,
well, I still have them.
You've been on how long? Maybe we're
getting close. We're getting
only
better.
60 days. Okay.
I tell you what, it's been a lot less though since I've been on it. It's been
really?
A lot less. What is it with the right hand? I mean, that's 3 of us now that have right hand tremors.
Dominant. It's your dominant side. You're left-handed or
No,
right-handed?
I'm right-handed.
Yeah. Everybody's right-handed, right?
Yeah.
Almost.
Yeah.
almost.
So it's dominant. Why? You're left-handed?
My brother Mike is. And so is my dad.
Mike's not here.
But me and Paul are both right-handed.
Yeah. It seems to be a predilection for the side that's dominant.
Mm-hmm.
So benefits, benefits can be relative to dopamine for stabilization. You were talking about the relationship between dopamine and prolactin. Is that dopamine is called the prolactin inhibiting factor. So when you look at your prolactin level, if it's elevated, it means you have lower dopamine. If you have depression of the prolactin, it means you have high dopamine. That's why I don't do the COMT studies anymore, is because I look at this surrogate marker relationship. Because we know that dopamine is called the prolactin inhibiting factor from the hypothalamus that regulates the production of the prolactin from the anterior pituitary or from the pituitary. So that's what I use to regulate it. Also, when people come in on the medication you mentioned, bupropion called Wellbutrin has a dopaminergic effect, so it raises dopamine. Some of the benefits of raising dopamine is you increase growth hormone, but you also in raising dopamine, you shut down the production of prolactin, and that allows more luteinizing hormone. So in effect, it can actually increase your production of testosterone and estradiol as an aside, as a crazy aside.
It's all about like looking at the patient individually.
Yeah.
And then listening to their symptoms. And sometimes you may go against the grain of what you know, but it's good for them. So
mm-hmm. And the homocysteine, do you check homocysteine concurrent to the,
Yes.
Because homocysteine has been found hands down to be predisposing to depression, cognitive impairment, and in people with TBI, it seems to be worse. It actually exacerbates symptoms relative to neuroinflammation because it adds to the inflation.
Yeah, the MTHFR deficiency can play a role in that, the certain ones. But then you also have to look at the rest of the B vitamins, because the rest of the B vitamins is in that cycle to bring down the homocysteine. So it may not be a deficiency in your genes. It could be B12 deficiency, trimethylglycine and all that.
And it also might be growth hormone deficiency, because the initiator amino acid of all our protein synthesis is methionine. And methionine is what becomes homocysteine. So how do you get so much methionine into the peripheral circulation to be converted into homocysteine? It's because you have interrupted ribosomal protein synthesis. And that happens from deficiency of IGF-1. That's why insulin-like growth factor, growth hormone is so important for repair, recovery, muscle repair. And that's why we use things like IGF-1 in some of our patients. But for the brain-derived neurotrophic factor, we've got a number of hormones, peptides that work very well. You might have seen the paper that was written by someone else, Oliver Fennell, about one of our patients, Gerald McClellan, who had a stroke 30 years ago. He came into our program 29 years after a stroke. I talked about it on Rogan, and he's 20% better in 4 months. And I'm not saying that. He's with a group of docs in Chicago where he's at. I'm just providing them directions, and they're implementing it all. So we can get recovery in stroke, not all stroke. I don't know. We don't have a large population, but it's interesting. We've done very well with the neurotrophic factors.
We are out of time. We need to ask this one last question. We love to end on hope and awareness, and we ask our guests what we obviously want both of you to take time to answer. What would you do to give hope to the audience regarding anything that we've talked about today, and for us, being involved with the research on CTE and head trauma and repetitive head impacts, what kind of hope would you give our audience? Doctor, you know what? Ladies first.
Well, I mean, never give up. If you really are truly wanting to get better, the people have resilience in the spirit in them to say, you know what, it's going to happen, where like you're going to run into what is it that you're needing help with. So don't give up. And even with a treatment that may take a little bit longer than others, because some people respond in 30 days, some people respond in a year, don't give up on that either, because we are going in the right direction.
Mark?
Absolutely. Well, awareness obviously is number one. If you are aware of that, there are alternative approaches to getting better with conditions like CTE, Parkinson's, Alzheimer's, dementia diseases, stroke, vascular dementia. I mean, there's so many labels that are given to the same problem, which is called inflammation. Understand that there is an incredible amount of information, which I've read some of. I've just scratched the surface to be able to deliver the medical care for the past 30 years to reverse a lot of these conditions, that it's there. And if you do your own due diligence, look at this, go to the medical journals, do your search, and then find out what they say, bring it to your doctor, and ask the doctor to implement some of the issues. If they won't, find someone else. And that's where the hope will be.
You enough.
Period.
We can't thank you enough, Mark, for being here. Mizyl, doctors, world-class doctors. Obviously, you know why Corey and I are involved with doctors like this. This was my Bible, little lowercase b. I learned a lot about this science, a lot of the things that you've talked about that I get glazed over in my eyes. You can read. I've some of these chapters I've read about 6 times just to get the gist of it. TB, I know we're going to have all of the links to your, TBIHelpNow.org, TBIMedlegal.com. I believe that's part of the Veterans Association that you work with, Mark. Is that correct?
Well, the educational site is the first one, TBIHelpNow.org, under the science. And the second one you noted is where people go to enroll in our program, or you go to the TBIHelpNow.org and you go under the TBI team, and right at the top of the TBI team is Dr. Mizyl, who brings a lot of important support to the system that we've developed. So if you are interested in Dr. Damayo, you just go there, click the button there, takes you right to her landing page, which shows our relationship for working together to treat TBI. Excellent. And there are other doctors, but
excellent. I know your two daughters, Allison, she's a doctor as well. She's involved with Millennium Health.
She takes care of all our professional sports people and our civilian population, who aren't in the professional world, but they get the same traumas: car accidents, weekend football games, hockey, MMA, a lot of MMA.
And your other daughter works with the gut health.
That's Allison.
That's Allison as well. The microbiome and all that fun.
My older daughter is the one who does hospitalist, who has moved into aesthetic medicine over the past 5 years.
Right. We love you guys. What a wonderful opportunity to have you in the studio. Dr. Gordon, Mark out in California, thank you very much for joining us via Zoom, and join us on the next episode of the Headrush podcast. I don't know if we're gonna beat this, but we're gonna try. So you guys have been just awesome guests. Thank you so much.
And I want to thank you both. And I both want you to come on again. I mean, this has been so informative and inspirational that you don't understand it. To someone like me that is a little bit further up in the spectrum of craziness. I don't know. But I do want to thank Mark Gordon specifically. You left the civilian world to go to the military. I'm going to get teared up right now. I have two uncles that served in Vietnam. One was a Ranger, one was a SEAL. I got a brother that was a Ranger. I got nieces and nephews that served in Iraq and Afghanistan. Man, I tell you what, don't worry about me. I got Damayo. I got everything else. I mean, what you do for our military by far, man, I thank you. My hat's off to you. It's amazing. You talked about going to the Pentagon, working in Australia. And I just want to thank you because our servicemen and women in uniform that protect this country, it's like I told Paul, it's amazing. We got a new House, a new Senate, a new Congress. We got a new president and a new podcast, the Headrush podcast. And I just want to thank you all so much and thank you for what you do to the military. I mean, by far, it's my hat's off to anybody in uniform. My brother was a Ranger and then went into LAPD, and he's retired LAPD. And, you know, I just want to thank you for everything you do for our people in uniform, and God bless you. And, you know, we'll come back and we'll talk about diet. Diet's a huge one that we're going to conquer. Matter of fact, I'm going to say it. I got a friend of mine, Nick LeDuc's going to come on. He's the one with...
Amen.
Yeah, he bleeds Amen blue, man. Let me tell you, he's Amen through and through, and the 20 superfoods and all of that. And we're going to bring him on to talk about that. So I just want to thank you again for everything with the military, Mark. I mean, my heart goes out to you and your family, and just thank you so much for that. And I hope you come back on. We're not Joe Rogan, but you know what?
You're not.
But we have Mark Gordon.
But we got Mark Gordon.
And Mizyl Damayo.
Yeah, he hasn't done Mizyl Damayo yet, so
That's
we're
right.
one up.
We were the first. We were the first.
Well, you're looking at my replacement right there.
Yeah.
Whoa, that's a lot to live up to, but I will try.
Well, that's why I'm going to push you.
You're doing it.
Yeah.
You're doing
Thank
it,
you,
Mizyl.
Mark, for everything.
Thank you so much, and thank you, Juan,
Yeah.
for coming and joining. This is Mizyl's fiance is Juan, and we just want to say thank you so much for flying down here to little old Texas from Florida.
He's a
And
Dallas Cowboy fan.
Thank you
and-
for coming on from
I was not happy with
California.
that.
No, he can't wait to go tour that little stadium down there in Arlington.
It's
So.
just small.
Yeah, I'll be back home in Magnolia, Texas in a week.
Great.
All right.
Safe
Well,
travels.
Safe travels.
Thank you.
All
Safe
right.
travels.
Bye now.
Bye. And for everybody else, like, share, click the button down below, subscribe. I never thought I'd say them words come out of my mouth.
You got two
God.
old gray-haired guys saying, subscribe. Push
I
that
know,
button."
ain't that
What does that
embarrassing?
mean?
I know. You know, I think I've only got like 4 things subscribed on YouTube. But, you know,
We want to bring messages of hope and awareness, and that's what this Headrush podcast is all about, and we're going to bring it.
right. And if you guys have any questions, comment below, and we will try to answer them on the next podcast. If you need to reach Mizyl Damayo and get involved and get into hers, it's
ParadiseBehavioral.com.
ParadiseBehavioral.com. She's tremendous. She's in Florida. I'm in Texas. We Zoom all the time. She's working with me. She'll work with you from wherever you're at. And you heard it from Mark Gordon's mouth.
Yeah.
She's the lady to go to. So we got direct lines. If you got any questions, reach out and we'll help you. There's hope out there, people. No matter what, we got hope.
That's right. And you end it by saying,
Stay alert. Stay alive.
stay alive. Thank you.
Thank you.
This podcast is for general information only and does not constitute the practice of medicine. The use of this information and the materials linked to this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard and delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.